Assalamualaikum. This is Mahnoor Wahid, roll number BP1650117. My topic is my drug is cycloserine that comes with the brand name of ceromycin. In this presentation we will discuss about that what is cycloserine, for what it is indicated, and also we will see one case study in which we will see that how cycloserine is used. So, cyclocerine is basically an antibiotic produced by Streptomyces orchidaceae. It is mostly used for gram-positive bacteria, and chemically it is a structural analog of D-alanine. So, it will prevent the incorporation of D-alanine in peptidoglycan pentapeptide. This process will occur by blocking the enzymes, that is alanine racemase and D-alanine ligase, that will convert L-alanine to D-alanine. Indications. So cycloserine is most commonly used in treating tuberculosis. Basically it is indicated for treating tuberculosis and gram-negative infections that are caused by Mycobacterium tuberculosis. Cycloserine is mostly used as a second line agent for treating tuberculosis when the patient is showing resistance to first line agents. It is also used to prevent kidney transplant rejection. The other use is that it is also an alternate choice of drug in minor surgeries. Rational and irrational use. First we will see what are the rational uses of cycloserine. It is used to treat pulmonary and extrapulmonary tuberculosis. Another rational use is that it is helpful in treating urinary tract infections only if it is caused by Mycobacterium tuberculosis, because cycloserine is only effective against Mycobacterium tuberculosis. Also I have discussed that it is useful as a second line agent for tuberculosis. Why it is useful as second line agent? Because it is less effective than other antimicrobials. So when the patient become resistant to first line agents, we will go for cycloserine. Irrational use, as we know that cyclocerine has a very narrow therapeutic window, so its dose should be adjusted carefully, because if overdose occur it will lead to CNS toxicity and psychosis. These are the doses of cyclocerine. For active tuberculosis in adults, we give 250 mg orally every 12 hours for 14 days, and then go up to 500 mg to 1 gram per day in divided doses every 12 hours for 8 to 24 months. In children, 10 to 20 mg per kg in day orally in divided doses, and can go up to 1 gram per day for 18 to 24 months. For urinary tract infection, initially give 250 mg orally and can go up to 500 to 1 gram per day in divided doses. In renal impairment, when the creatinine clearance is 50 to 80 ml per minute, we administer every 12 to 16 hours, and when the creatinine clearance is 10 to 49 ml per minute, administer every 24 to 36 hours, and when the creatinine clearance less than 10 ml per minute, then administer every 36 to 48 hours. Contraindications and drug interactions. So cycloserine is contraindicated in patients with epilepsy, hypersensitivity, renal failure, and mental disorders. The different drug interactions that occur when used cycloserine with other anti-tuberculosis medications, like it may lead to folic acid deficiency or mucoplastic anemia, and can also inhibit phenytoin metabolism that can cause epileptic seizures. Also the consumption of alcohol may cause convulsions. Now the toxicity and antidote. Toxicity of cycloserine occur when the high dose is given or if the patient have insufficient renal clearance. Most common toxicity is that patient may develop allergic dermatitis, or also there is a high chance of CNS toxicity that may cause psychosis, depression, headache, vertigo, etc. Overdose of cycloserine may lead to seizures or coma. So in these conditions cycloserine should be stopped, or maybe we have to adjust the dose of the drug. Antidote for cycloserine is that if the toxicity occur, then the pyridoxine given as an antidote in the dose of 100 mg per ml in solution form, or if it is in tablet form, then the dose should be adjusted between the 25 to 500 mg depending upon the toxicity or the condition of the patient. Are the alternate brands of cyclocerine. As I have discussed that cyclocerine comes with the brand name of ceromycin. So the other alternate brands of cyclocerine are Cyclocerine capsule, Clocip capsule, cyclocerine tablets. These brands are easily available in Pakistan and the prices of these brands are mentioned here. The alternate choices of cyclocerine are rifampin and vancomycin. These are the alternative choices to avoid toxicities, as rifampin and vancomycin do not cause very much CNS toxicity. They have very few side effects of CNS and also used as in tuberculosis treatment. Cyclocerine is only available in oral dosage form like tablets and capsule. It is not available in solution or parenteral form, so it will be given in tablets or capsule form only. I am going to discuss one case study. There is a 40-year-old woman who is admitted in hospital with the shortness of breath. She has lived in sub-Saharan Africa and also she developed a non-productive cough few weeks ago. Lab test shows that bronchial flushings are smear negative for acid-fast bacilli, but Mycobacterium tuberculosis is isolated from the sample. Also, the early sputum samples are negative, but later samples are positive. What we are going to discuss in this case study that what form of TB does this patient have, what treatment should she receive for her TB, is she at low or high risk for drug-resistant TB, and what further microbiological investigations would be essential, and what treatment should be given if it is drug-resistant TB. These are the soap notes. In subjective, the age of subject is 40 years, gender is female, chief complaint is shortness of breath, and the duration a few months ago. Objective is lab reports. We have discussed that bronchial washings smear negative for acid fast bacilli but positive for Mycobacterium tuberculosis, and also the sputum sample is early negative but later the samples are positive. The symptoms and the lab report suggest that the patient have pulmonary tuberculosis. So the plan for treating pulmonary tuberculosis is that we should start with quadruple therapy that comprising of rifampicin 600 mg, isoniazid 300 mg per oral Q-day, supplemented with pyrazinamide 15 to 30 mg per kg and ethambutol 15 to 25 mg per kg once daily for the first 2 months. But the change in the sputum smear status that become from positive to negative shows that the patient is developing multi-drug resistant tuberculosis. That means that the drugs we are using are no more working and become resistant for the tuberculosis. So we have to perform several tests like PCR tests should be done to determine whether the infecting strains of bacteria are resistant to quadruple therapy or not. And if the PCR test suggests that the infecting strains of bacteria are resistant to quadruple therapy, then we will move toward the second line anti-TB agents that are ethionamide given in the dose of 15 to 20 mg per kg twice daily, kanamycin 15 mg per kg, ciprofloxacin 750 mg twice daily, cycloserine dose is 200 to 500 mg twice daily, and clarithromycin dose is 500 mg twice daily. These are the second line anti-TB agents and given when the quadruple therapy or the first line agents are failed. So the patient was diagnosed with pulmonary tuberculosis and we have first given her a quadruple therapy that includes rifampicin, isoniazid, pyrazinamide and ethambutol for the first 2 months, but later the sputum samples came positive that shows that the patient is showing resistance to the first line drug. So we will move towards the second line treatment. Also we will suggest some lifestyle modification to patient to avoid public meetings or remain isolated in order to avoid infecting others, or also to take medication on time. These are the references from where the material is taken.